Yeah. Okay. Good morning to you all. Sorry about short delay in our starting, but just putting the finishing touches to our tech. But really good to see you all. Hope you all had a good summer, and what a delight to be back in Kensington to this wonderful town hall. And thank you to our friends at Kensington Chelsea for hosting us once again this morning. And what a bonus to be joined by the Chief Executive, Maxine. Very good morning to you, and please say a few words.
Yes, so firstly, thank you all for coming here to Kensington Chelsea Town Hall, and welcome to the view of Kensington Chelsea Town Hall to colleagues on the screen. So I'd like to welcome the councillors from across the North West region and health partners as well. It's really great to have you here, and it's so nice to be able to kind of get together. I can see that you've got a huge amount on the agenda today, really important, critical stuff. I know that we have lots of challenges across the North West region at the moment in terms of meeting the needs of our residents, all the health needs of our residents. So I'm going to hand over to Councillor Knight for the next little bit, and then I will be leaving to your meeting. Welcome.
Thank you very much indeed, Luz, to Maxine for those very warm welcome. Thank you very much, Lucy.
Thank you. Before we proceed the meeting, I'd ask members of the committee to please make sure your mobiles are switched off or on the silent, and I think it would be appropriate for us to start with 72 seconds of silence to remember those who lost their lives in the Grantham tragedy.
Thank you very much, everybody. And Maxine, thank you very much. So colleagues here in the room and on the screen, again, very welcome, and particularly to our NHS colleagues. Really good to see you all. And you should all have the papers for this morning's business, either in the paper format or electronically, and we will be looking at those in just a wee moment. But before we do that, let me just ask Emily for any apologies.
We haven't received any.
Thank you. And declarations of interest list. So let me begin with mine. So I'm the lead governor of Central and North West London NHS Foundation Trust. Colleagues, anybody? Okay. So then we come to the minutes of the previous minute, and if I can ask us to take this as tabled, and grateful to our England colleagues for producing those very helpful minutes. Any matters arising, please? Thank you very much. And so we now come to our first substantive paper this morning, and this paper will be familiar to us all, and we've got the proposals for consultation on North West London wide review of palliative care, end of life care, and we've got our NHS colleagues, and rather than going through all the names, I'm going to ask Jane Wheeler. Good morning, Jane, to
Morning,
present the
Catherine.
paper, and if you want to bring any other colleagues to supplement any presentation, then I'm very happy for that to happen. But good to see you, Jane. Good morning.
Thank you very much, everybody, and sorry not to be there in person.
Your
It's my
microphone,
seventh-
please.
Oh, can you hear me? I'm not on mute. Can you hear? Can people in the room hear me? I'm not getting a
No,
response.
we can't hear you.
People on.
I can hear you.
With your headphones.
It should come out. And we can play it through.
Hello?
Anyone, it should be coming.
Sorry, everybody, just a little pause while we sort out the technology. If you could just all bear with us for a moment or two longer, please. Let's see if we can hear on anybody else. Michelle, can you just say hello to us? Rory, just say hello to us to see if we can hear you.
Hello, can you hear me?
No, we can't hear you, Rory,
Hello.
either. Michelle?
Hello. No.
No, but can you hear us?
Yeah.
Oh, you can hear us, but we can't hear you, unfortunately. Okay. Let's just see if we can resolve this.
The settings thing is on your left.
Yeah, I think as we can play out the laptop first.
So we're just going to see if we can resolve this tech issue. If we can't, then we of course have the chief executive of the ICS, Robert, and I will invite him to present on behalf of Jane. But we'll just see if we can fix this tech problem.
If we put out your laptop, how loud is it?
Should we see it?
Yeah. Would someone mind speaking quickly, please?
Hello? Hello?
Jane, can you just say something?
Yeah, hello. I'm speaking. Can anyone hear me?
Okay. I think what I'm going to do, if it's okay with everybody here in the
If we put out your laptop, how loud is it?
Yeah, should we see it?
Oh,
Yeah.
wow, got it fixed. Well done to our tech expert.
Would
Hello?
someone mind speaking quickly, please?
Hello? Hello? Hello?
Jane, can you
Can
just
someone
say-
hear me? Can anyone hear me? Can you hear me? Hello?
We can hear you loud and clear, Jane.
Yeah, a little bit. Yeah.
Okay, Jane, say
Hello?
something now.
Hello? Hello?
It's really
Jane to
It's very, very
RBKC.
faint.
Jane to RBKC.
Okay,
Maybe it's okay to put somebody else.
somebody else? So, okay, Rory, say hello.
Hello, can you hear me?
No.
Oh, he's on mute.
Michelle, can you just say something?
Hello? Can you hear me? I'm seeing a nod, but don't think that's people hearing me.
Is it better if I shout? If I'm louder, can you hear me?
As possible so that Jane doesn't have to shout too loudly. Jane will try, but if it is difficult for all of
Yeah.
us to follow, then I think what we'll do is we'll ask Rob to present or supplement the presentation that you're going to make, if that's okay. But let's
Yes.
just see how far we go with your presentation and the sound quality.
Fine. So we last came to you some months ago about the development of this work, and we are now at a stage where we have co-designed with residents over the last year what we think is the proposed model of care for the core ingredients of service that all residents of North West London should have when they need specialist palliative care services in the community. That there are other developments we're working on in the wider pathway around end of life, advanced care planning through the Universal Care Plan, and work around integration with community nursing and other universal services. But our model of care document focuses on the key ingredients that good looks like. What this paper does not set out is how we should commission those, how we should deliver them. So we are currently engaging on the model of care, which is the what, and that says a number of things need to improve. Not all of our boroughs have the same support available for people in their own homes. For example, hospice at home, and the community nursing that is available is not always available 7 days a week. The support that people get through outpatient type clinics is also not consistent, and that also covers things like bereavement. And we know that the access to beds when people need beds is also not consistent. The work has shown us that we currently have some unmet needs around people who need to be in bedded provision, people who, for whatever reason, the quality of their housing or their social circumstance cannot stay at home, but do not need to be in a hospital bed, are currently underserved across our population. And we are proposing we need bedded provision that supports that set of needs. Not people who are heading towards a complex death, which needs a full MDT, but people who need to know they are somewhere safe and therapeutic and have access to the specialist team. We are proposing that we need to address all these gaps as part of our development, and we're just engaging over the coming month on finalising that document. We will then continue to engage on the options for how we deliver that before we progress to a consultation stage. As people in this room and wider know, it's really important to us that we continue to do this in an open and transparent way so we can really evidence the resident voice and other stakeholders in the outcomes that we get to. I've really simplified my spiel here because it's really hard. I feel like I'm shouting at you. So I'm going to stop now because I think I've covered the key points and open up to questions. I do think there's an option if you can't hear me for me to call Rob and put me on speaker. It may well be clearer and might be worth a try.
Thank you very much, Jane. Really grateful to you. Rob, do you want to say a couple of words, quick couple of words?
All I would say, just acknowledge that this there's been a lot of work taking place for some time on this, and we continue with the spirit of what Jane's saying in terms of the engagement process to co-produce and finalise the option for a consultation, and grateful for the opportunity for the advice of this committee in informing how we take those next steps going forward.
Thank you very much indeed. And Jane, you have your colleague Michelle with us as well. And colleagues, we are now going to open up to some questions. And Lucy, your first question.
Firstly, I just want to say that there is a lot to be welcomed in this paper, and it's very evident from it how much effort has gone into the listening and understanding of people, what people want in palliative care to look like for our community in years to come. My first question is about inequity and access to inpatient beds. As you yourself referenced this, as a result of our ageing population and the changes in patterns of mortality, how will the new model of care ensure that there is a sufficient capacity for inpatient beds in the future? As the report highlights, an extra 3,000 beds will be needed by 2033. I'm going to go to my next two questions and then hopefully they can be answered. Second to this, is the Pembridge Hospice considered to be part of the capacity of inpatient beds in the future? And what is the update on this? Is there, as we have heard, nothing with regards to the status of the consultation, where the consultation is got to on them? And lastly, I just wanted to ask about workforce, as this will be critical to the delivery and success of this new model of palliative care. How can we ensure us that we can recruit and retain the workforce needed when we are currently facing a shortage nationally of specialist palliative care professionals, including palliative care consultants?
Thank you. Well, good, three good questions. Let me turn to Jane first, and then I'll bring the other colleagues in. Jane?
We have done a lot of detailed modelling for the future demand, and the 3,000 number that you reference is the people who will need specialist services, not those who need bedded care. We have not just looked at projecting forward based on our current activity, but we have undertaken we commissioned an academic partner to work with us on modelling unmet need, because we were concerned about modelling forward just what happens now and that not reflecting unmet needs. So the number that our projections show that the capacity we are proposing we need will be sufficient for 7 years. We have a much more detailed briefing paper on that, and I'm really happy to pick up with individuals who may want me to walk through that. In terms of the workforce, one of the benefits of this work and meeting over a 38-week period is our providers have been working even more closely together, and that includes on workforce development opportunities, on shared approaches to recruitment, on shared approaches to supervision. We know that across North West London that recruitment is easier where you have services that are sufficiently resourced to deliver in a way that means the people working in those services are not at excessive strain. We also know that giving people careers ladder and opportunities to progress helps us in our recruitment processes. Our providers are signed up to this as a plan that is both ambitious and realistic over the next 5-year period, and that includes the ability to resource to deliver it. I don't want anyone to get impression that this is all going to happen on one day. This is going to need a multi-year plan to bring in these proposals, both in terms of the workforce, but also in terms of the organisational development and the changes we want to see. Some of this can happen fast and some of it will need to phase in. And as we move to that next stage of consultation on how we deliver this and what the commissioning model is, we're going to need to articulate that phasing much more clearly and test that with you all as well. But our providers think this is deliverable and also will help them retain the workforce that we've already got, which of course is fantastic to give our current workforce opportunities to grow and be part of our future. I think I've missed your middle question. Sorry, Lucy, I touched on it. Pembridge. So the modelling takes into account the current activity across all our boroughs. So some people who would previously have gone to Pembridge are now going elsewhere, and we reflect that activity into our plans, and we reflect the unmet need that might relate to people who could go and have those needs but aren't going. And that's the basis of the modelling. It will be at the next stage when we talk about options for delivery that we talk about where that Pembridge sits in those options. It's always going to need to be one of the options, but right now we wanted to get to the what rather than the how we deliver it, because otherwise we're kind of caught in ultimately every option was possible, and modelling that up we were getting quite stuck in that. What we think got is some fixed points that we can then model how we deliver that best rather than everything shifting. So it was hard to model, and you'll see most of the changes we're proposing and the improvements are about services that are not in our bedded units. The majority of people don't need bedded care, and so really improving support in people's homes, which has been happening during and after the pandemic as that shift has occurred naturally. Improving that care in people's home means we can really deliver on that desire of people to remain in their own homes where that is what they want.
Great, thank you very much. Lucy?
I welcome everything you said. So there's no sort of the actual update on where the consultation on what kind of timeline we're looking to for Pembridge. There's
So the timeline is we will be seeking, assuming each of the steps I've outlined progresses in terms of engaging both on this model and then on the options, we will be looking to consult through the winter months for the entirety of North West London of how this model should be delivered. But that will include, of course, where Pembridge as one of those options for delivery going forward.
Thank you very much. Natalia, please.
Thank you, Chair, and thank you very much, Jane, for the introduction and the paper. I also know what Lucy has said in terms of the work that has been put forward. I just have a question in terms of the engagement process. How are you going to be engaging and reaching out to diverse communities?
Mm-hmm.
The communities of different faiths, different ethnicities, the LGBTQ plus community. How does that co-production look like? Can you please give us more details? Thank you very much.
Thank you. And maybe, Jane, if you could start and I'll bring Rory in.
Great. Yeah. I think the engagement on this, I've always seen it needs to be a matrix of working across North West London, working at borough, and then working with special interest groups, particular demographic groups which have particular needs. And that was the approach we took from the beginning. You'll see on our website we've published all the outcomes of our initial work with the different groups you describe. Of course, though, there are always new needs that are being articulated to us. We had an evening session last week with a lot of debate about paganism and where does that sit in our work. It wasn't something we'd picked up previously, and so we're not always going to have covered everything, but really open to continuing those conversations. So at the start we had those conversations, and that gives us the same people to go back to and said, you told us these were your problems. We've articulated those are 8 issues that exist. We think the proposed model addresses those issues, and this is our chance to test that back with people. But we're also doing borough engagement, as I'm sure you know, for Hammersmith and Fulham. We have a number of sessions both across North West London and in boroughs to have those conversations. And of course, all those groups will also sit in borough. People don't sit in one box. So I hope in that approach, we're trying to give people those opportunities to test. The key thing we've heard from all groups is that importance of their needs being treated as individuals, and actually as much that sense of personalised care and people listening to them and being that kind of honest conversation about what's available and what they should expect. I think our proposals around a 24/7 advice line really respond to that. The biggest theme we heard, regardless of what group or borough we spoke to, is relatives and patients don't know who to call. They don't quite know where to go. It's a complex system, and that's right. People need lots of services and lots of support. Everybody's combination of services is going to be different. There's no roadmap that we can publish for everybody. But knowing that there's a 24 advice line that they can call and have someone who can help them with that navigation absolutely responds to what we've heard universally across our populations.
All right. Rory, did you want to just supplement anything that Jane has just said?
Yeah, I don't really have anything to. I mean, Jane's answered that fairly perfectly from my perspective, so I don't really have anything to add. I should introduce David, who's been supporting the engagement, is also on screen. I don't know, David, if you've got anything else to add to that.
Hi, yeah, just to add to Jane's point that we published fully all of the details of our engagement to date, which is in a report on our webpage, and within that is a table of the different conversations and groups we have met with. Sorry, I haven't got it in front of me, so I won't try and cover them all now, but it's fairly detailed and covers different religions, ethnicity, sexuality. So I think we've been quite conscious of that throughout the engagement process, the need to try and reach into these groups. Some of those were referred through events and people that we met when we were doing the engagement. Others we proactively reached out through other contacts through the ICB when we were conscious that we didn't feel particular groups may have had their voices heard within the work that we were doing. So we're very happy to follow up.
Thank you. And I think this is your first visit to the committee, so good to have you, David. Let me go to Chetna, please. Chetna, good morning to you.
Good morning. Thank you for the presentation. With regards to the model of care for enhanced care bed, do we know what the criteria is for determining the appropriate length of stay for patients at every stage? And how will the team facilitate smooth transition of stepping up or stepping down care based on evolving needs? And who will be making those decisions?
Thank you.
Fantastic question. I'm just going to say a little bit. I'm going to turn to Michelle on the particular Porterbike criteria. I think one of the things was by describing our model in different buckets, there's a risk that people see that they are sitting in one bucket of the service, whereas the majority of people will need little bits of all of this service. And what we're proposing is that to make that feel more joined up, we need that care coordination function much more clearly picked up for people who are known to specialist services. So that ability to have that single person that you can go to, which helps in terms of that step up, step down. One of the things that surprised me through this work is how many people who are in our hospice beds, that's not ultimately where they die. Seeing both that as respite, but also something that people can step into before returning home with the right package around them is a really important part of the fluidity of responding to needs and enabling people to be where they want to be during that last period of their life. Michelle, can you say something about the specific criteria?
Yeah, so one of the things that's really come out through this working with our providers is a much clearer understanding that hospice inpatient beds really are not a long-term stay place, and that the intention is for, you know, intensive care over a 2 to 3 week period to stabilize somebody and then ultimately be able to return them to their place of care previous, so whether that be at home or whether it be at a nursing home. And the enhanced end-of-life care beds, what we have is in Hillingdon, we actually have 8 of them that are currently running. And they have come up through their model with a 3-month length of stay. Now, that's not to say that our model is going to definitively say 3 months, but that's what we've got working at the moment in Hillingdon. And the way that it works is you've got the community specialist palliative care in Hillingdon who review those patients regularly. They're looking at their needs and they're working with the MDT to then say, right, is this bed provision meeting this patient's need? Do they need to be stepped up and moved to a hospice bed? Can we continue to manage them here in the nursing home? But most of the time, the intention is to not move people too much. So if they can support that patient in the nursing home once they've transitioned there, that would be the intention. But of course, if their needs change, then they will review them and make that decision. So there will be, you know, within our new model, there will be referral pathways in place so that those teams reviewing that patient can connect with the hospice team and transfer that patient as needed to a hospice. Or sometimes we've even had cases where patients have actually stabilized in a nursing home end of life bed or enhanced bed that we have in Hillingdon and have returned home. So, you know, I think to Jane's point, the intention is that we want this model to meet patients' needs at every step of the way. And we recognise that there will be those differences in needs that will go up and go down as they move through their journey of palliation and end-of-life care.
Great, thank you very much indeed. Let me move and progress this to Marina, please.
Hi, thank you, Chair. Well, thanks for the presentation. Could you confirm whether the review would be presented to the Hounslow Borough-based Partnership Board for local discussion, and how Hounslow can actively engage in this initiative? And it's my understanding that Meadow House have conducted a review, and they said that they're struggling to meet capacity. They only have 15 bed capacity, and since COVID, their day centre, their palliative day centre has been closed. And also, Hounslow residents were not involved in the model of care working group, so we'd like their input to be integrated into the implementation process.
Thank you for that, Marina. Jane, please.
So we have attended the Hounslow Palliative Care Forum. Apologies if that name's not quite right. They're different in each borough, but it's great that we are invited in and part of those forums at a borough level specific to palliative care. We have linked with both the Borough-based Partnership Director and the Borough Director to come and speak at any relevant forums. We have quite a schedule going forward for some boroughs, but when you say that, I'm not sure we've been booked in for anything in Hounslow, so we'll go back to those director leads in the borough and make sure that that happens. It's really important that all boroughs have the opportunity to input through wider than just their palliative care forums, because this touches everybody. In terms of Meadow House, yes, we're really aware of the pressures there. And we're also really aware when we look at access across the sector that whilst we've talked a lot about our inner boroughs, which is really important, and I'm not dismissing that, when we look at travel times, it is the growth of population down in the south of Hillingdon, the far west of Hounslow, that has the worst access to our inpatient units. And of course, that growth of population, particularly in the Hillingdon village area, is putting pressure on services out in that direction. So as we start planning for what our commissioning model is, we need to take into account that distribution of current challenges and also the current population growth, which is focused in some of those areas, because we are aware very much on those pressures on Meadow House, which can also be seen into Harlington as well from that south of the Hillingdon patch.
Thank you very much for that. Claire, please. Good morning.
My question, in a way you answered possibly in your introduction, which is this advanced care planning seems crucial to the success of any palliative care programme. And so I wanted to be sure that resources were going in a big way towards advanced care planning.
Thank you.
We're delighted to hear you say that, because we completely agree. And of course, advanced care planning isn't just about the specialist services. Advanced care planning is for everybody. So it sort of has an interface with this work, but has a separate programme all of its own. Around now, we have the Universal Care Plan, which crucially can integrate with the London Ambulance Services systems, so they can easily access what people's wishes are. We need to really promote the uptake of that. We know that where people get to articulate and record their choices, there is much more likelihood that that those are delivered at the end of their life and throughout that period of time. So it's really critical. We now have a dashboard which is tracking through that delivery and really helpful. Anything you can do to promote that locally in your boroughs, we'd really welcome your support. It's a really important ingredient in delivering what residents need. Michelle, were you wanting to add?
Michelle,
Yeah.
please.
I just wanted to add, just in terms of advanced care planning, it really is the bread and butter skill of community specialist palliative care teams, and part of the new model is also looking. So there will be more primary care.
Sorry,
Can you hear me now?
Michelle.
I was saying, so,
Yes.
so part of the new model is particularly around primary care. We're looking to support our specialist palliative care teams and the hospices who have, education programs to support training primary care GPs, district nursing around doing advanced care planning and ensuring that that then travels through to UCP record or Universal Care Plan recording. So yes, it's integral and underpins our model, but also goes wider, as Jane says, into the sort of generalist palliative care and care planning space.
Great, thank you. Lucy, please.
Two further questions for you. Is the expectation that patients will have to travel further as part of the new model of care to access community-based services? And where will the new community beds be provided? And secondly, how will the new model of care particularly help those with complex needs?
Jane, please.
So people to go if can't stay at home and shouldn't be in hospital. So we think in terms of actually responding to people's needs with the right support as part of an entire system means that those with the most specialist support have that much easier access to the capacity and the skills that they need. And so that answered your second question. Your first question is about where will beds be. This stage of work is not defining where any of our units will be. As we come to the options in the next stage, that's what we're going to be breaking down, all those different options. We know there are areas outside of London that are centralising their provision so they can have all that specialism in one place. We know that there is a big desire that we have all services in all boroughs so that we have that real integration with other services, which is critical. We've got to set out all those options and discuss those with people. At this stage, what we're trying to say is that what are we optioning? What is it that we're saying is that standard that we can then look at how it should be delivered? So through the middle of October, that is the conversation we'll be having with partners. OK, we've all buttoned down what we think the model should be. Now we've got to get to how do we structure ourselves to best deliver that, and what are the trade-offs and the pros and cons in terms of opportunities for workforce to be work between bigger teams, which we know can be more attractive, versus local access, and actually being very transparent about those being the kind of decisions that we're all going to collectively make so we can really best deliver the outcomes that residents need. There will need to be those trade-offs. These are relatively small services. In the main, these are not services that can be in every PCN, and in some cases currently span very large geographical areas. So just doing that work about what that will mean for different people, those different trade-offs, is critical, and doing that with you as options will be the next step. So
PCNs are primary care networks. OK, thank you. And all of that work will continue by way of continuing to engage not just the key partners, but all the other groups that you have been referencing throughout this morning. Jane.
Absolutely.
Great. Angela, please.
Thank you, Chair, and thank you for the report. You've partly answered my question, but the community engagement report does detail concerns about communities accessing services in a timely and appropriate way that reflected faith and cultural needs. What are you doing?
Thank you, Angela, for that great question. Jane, please.
Fundamentally not enough yet. As we are progressing to the key ingredients of this service and starting to work up options for that, it's really clear that that work around our services being culturally sensitive, culturally competent will need to happen regardless. It's almost not an option. It's not something we can either do or not do. It needs to be done. And so what we have, the model of care group that developed this work has now come to a close. We thanked them and closed it down. But what we agreed was that we needed a number of streams of work coming out of that to work across with our clinicians and our residents to actually turn that desire for our services to be much more inclusive and culturally competent into a delivery plan. But that doesn't affect our options. That will be regardless of what our options for how or where we might deliver the service elements of this work. We will absolutely do that work. We've just been, in terms of timing, sorry, Captain.
Thank you. Thank you for that, Michelle. And I don't know, Rick, and then point from Michelle to begin with.
I just want to say so that all of our providers are really committed to being more inclusive, and a lot of them are doing some excellent work as it stands. So, you know, a lot of our providers will already provide culturally sensitive meals, culturally appropriate religious support. We don't have every sort of religious leader within all of our providers, and that's not a realistic ask to have. But what they've committed to is personalisation, so that care is as personalised as possible, and that they are then asking that person what's important to them and having that as their ethos, and then going out into their local community to find those faith leaders to support them in their care delivery. So it's really about strengthening those local partnerships, but also having personalisation at the heart of all of this.
Thank you. Thank you very much for that. Let me bring Natalia back. Natalia?
Thank you, Chair. I just have a question about carers. What is the offer for carers in the palliative care review, please? And what's the probability for carers, please?
Another good question. Thank you, Natalia. Jane, I don't know if you want to pick that up, and then I'll bring as appropriate of the colleagues.
So in terms of the support for carers, that is a key part of, if we're talking about carers as informal carers, family and friends and loved ones rather than paid carers. So one of the key roles of the service is around support that we give to those carers and those loved ones in people's homes, and raising up the expectation around what that might look like in terms of access to bereavement support, access to like psychological support, is that side about protecting people's well-being. However, we do know that this is about practical support, isn't it? That people feeling that they are there alone with their resident or loved one, and they don't know relative or loved one. And I think that 24/7 advice line is such a critical part of that support, knowing that you've got somebody who's at the end of a phone who's got specialist advice and can say, no, that's normal, it's okay, or no, that is a problem and you're right to be escalating this, or, you know, there is something we can support you this evening, or actually that is one that we need to be supporting in the morning. But giving people answers so they know that they're not having to navigate this themselves is absolutely critical. And I think that combination of the wellbeing support and also that practical access 24/7 is how we can make carers feel less that this is all on their shoulders, which is some of what's been reflected back to us.
Thank you very much for that. Michelle, a quick point before I go to Jeff now. Michelle.
Just wanted to say one of the main sort of elements of the care is hospice at home that really is key for carers, that it's very different to a normal care service like continuing healthcare or social care that's going in. They do have the ability to sit with patients for up to 4-hour blocks, whereby a carer might be able to go out and you have trust that that patient is being looked after and cared for in their home. So that really is one of the kind of key elements for respite. And then we do have respite for our most complex patients in hospice inpatient units. That's obviously on a case-by-case basis, and that's really for patients who cannot be managed at home with their usual care package. There is those elements for the most complex care. So it's thinking about that and care information, as well as part of our wellbeing services, where you'd have bereavement support as well as advice about funeral planning and will making and, you know, advocacy around that.
Great, thank you very much, Michelle. Jen, I'm just coming to you, but Marina has a very quick supplementary point to follow up with.
Thank you, Chair. Where will we be getting the staff from?
So it depends which bit of the service we're talking about. So one of my gaps I'm most concerned about is.
So, 1 second, Jane. 1 second. Sorry.
Just apologies.
You're saying that they could be doing block visits like 4 hours at a time. Those sort of staff members, like day carers, I suppose.
So that is a NHS funded caring workforce, and we know that there are pressures, and we have been talking to our directors of adult social service colleagues about whether this is something that puts more pressure on those services. We also know that for our carer workforce, taking on additional specialisms, being linked into professional MDTs, is a career development opportunity, which may be for people who would otherwise leave the profession because they are in roles which don't necessarily have that progression. So what we've seen elsewhere in the country is that this is an opportunity for people who are currently within our caring workforce, may feel they haven't got those development opportunities to take on a specialism and progress into that role where you're a carer who has a extra training and extra support around end of life care. And that is an opportunity to keep people in our workforce. We're going to need to be really careful because there are real pressures in our carers workforce and we can't add to that. However, if this means we're keeping people in the workforce through those opportunities, I think that's positive.
Thank you very much for that, Jane. And I'm going to come to Jetna for the final question, please.
Thank you very much. What steps are being taken to standardise hospice, outpatient, daycare and community-based specialist palliative care wellbeing services to ensure consistent level of quality of care across the services and across the boroughs? And is there best practice we can use within the NHS that is working in other parts of England that we can rely on? Thank you.
Thank you for that, Jetna. Jane, please, very briefly.
There's absolutely best practice, but there isn't an off-the-shelf answer for what the right answer looks like, which is why I've had to co-design in such detail. But we've done a lot of looking across the sector, not just in the NHS, but of course in the charitable hospice sector, about what good looks like, and we'll continue to learn from the networks we have nationally. The important thing about the wellbeing services, like all of these services, that many of them are co-funded with charitable funding. And one of the key steps that we've taken is being able to identify what services are entirely hospice funded, and that is some of the services the NHS wouldn't have a responsibility for, and what is jointly funded, where we are agreeing those common minimum standards we'd expect, whether it is about the professionals involved, the hours available, what the service looks like, and doing that across those wellbeing and outpatient services, so we've got that consistent offer as the work we've done here.
Thank you very much, colleagues, for those some excellent questions and again some very helpful replies to those questions. Grateful to all the colleagues here and the colleagues on the screen. So I'm going to bring this paper to close now, but before I do so, let me just see if there are any recommendations that we feel we ought to be making. So first, Ben, please.
So very grateful to colleagues for today's presentation and also for the engagement work that I know that you're doing with our co-production board at Ealing. Today we've heard lots about working together seamlessly, support, step up and step down. And I know, Jane, that you mentioned in your introductory remarks that how is to follow. But I'd like to suggest that colleagues look to design some principles for how the services will work together so that patients and their families can hold partners to account following the implementation of the new approach. So that would be my recommendation, Chair.
Thank you very much. And I can see some colleagues nodding their head in agreement. So thank you very much for that. Good recommendations. And are there any other recommendations? Claire, please.
So mine was just that advanced care planning was integral to the whole process. But I think it sounds like it already is, but perhaps it's something we could maybe bring up again to future date.
Thank you very much. I can see colleagues nodding again, and I can see Rob in agreement as well. So thank you for that. Jetna, please.
A couple of recommendations, if I may.
Thank you.
Can we see what a standardised, quality of care looks like within palliative care, well-being across the boroughs for North West London? What is that standardised care? And also another recommendation on the how factor. What resources do you currently have, and what are the gaps? And how will you fill those gaps? What is the percent? What is it? Where are the gaps, borough by borough, and how will you fill those gaps? It'd be good to look at that detail of work, if possible, at some stage. Thank you.
And perhaps also, how will you be monitoring that? How does that pan out going forward? What does the good look like, and how are you going to be monitoring that? So I think, thank you very much, colleagues. Grateful to you. We are now going to make progress and those colleagues who needs to leave, I understand, but look forward to having your company at future meetings. But thank you for the time being. So we're now going. I'm going to slightly rejig the running order, if that's okay. So we're going to be looking at Northwest London mental health strategy first, if that's okay. And we've got colleagues in the room who are going to be presenting the paper first. Caroline, is it you or is it Katie who's going to be presenting the paper?
I think I'm going to start, Chair.
Thank you very much, and really good to see you this morning in person. I know you have other commitments at the trust, but we are grateful for making the time to join us this morning. Thank you.
Thank you, Chair. So I'm going to kick off on paper 7, which is an update on the mental health strategy. And Katie followed on the screen, and Gareth Jarvis is also a big clinical lead for the programme, so might want to come in. So this is where we are at this moment in time. We're doing some data analysis to look at the need, the presence and the demands that will be available at the end of September. We've had a really good working group with all boroughs represented, all local authorities have input to that piece of work, and we've done some engagement events. You've got a very short highlight at the end of the paper of where they are, but that's been added to both in terms of face-to-face meetings in each of the local authorities and also some online discussions this week and going into this month. The approach has been to build on the JSNAs, which exist, to pull out the key themes and to set out some principles. Interesting that came up in the last discussion, but what are the principles around mental health, drawing on the Northwest London strategy, which is like-minded, and also the national long-term plan. This is only looking at adult services at the moment. The phase 2 will bring in children and young people. So I think in the interest of time, I'm happy to stop. I don't know if Katie wants to say a few words and then open for questions.
Katie, very briefly, if you want to add anything, and of course, Gareth in the room, if you want to add anything very briefly. Katie, good to see you.
Thank you. Just to add to that, so just in terms of timeline, so we're looking for our first initial draft in October to be able to share with stakeholders.
Thank you. And before you finish, Katie and Caroline, just wanted to understand why the phased approach, please.
So when we talk to service users, there are a number of different issues, I think, looking at children, young people compared to adults. One of the key themes is transition, so young adults between the ages of 16 to 25. So the next phase of the work will look at that group, and that was emphasised in the seminar we had with councillors last week as well. But we wanted to just chunk it up into bite-sized pieces, really.
Great, good for that clarification. Marina, please.
That's really true. So Council supports the general strategy, but not the approach that's being taken. It would be beneficial for the strategy to be reviewed and considered by the Hounslow Borough-based Partnership Board to allow officers to comment on papers such as this. So, for instance, how the strategy ensure alignment and complement with jail county with local initiatives. There are concerns it would duplicate the work of our local European strategy. And it would also be beneficial if the strategy explored a greater focus on appropriate bed use and ensuring sufficient community provision for mental health patients. So, for example, how can acute bed usage be optimised for those in crisis to improve collaboration between partners and interlocal authorities?
So I would just ask very courteously, without being rude, if the replies can be somewhat shorter, so we can get as many questions as possible, and also to make up the time that we lost with the tech issues. Thank you.
Thank you. So there have been discussions with the Borough-based Partnership in Health. There are, I think, 2 reps from there on this working group. Always happy to have another discussion. I think the point you've made about best use is important. There are very differential ways of managing the beds across Northwest London, some with very excellent, good practice, short length of stay. I think one of the limiting factors in some places is supported housing. And again, we're talking to the adult director of social care and also through them, the housing directors, about what we can do to support that.
Thank you for that. Let me bring Lucy in, please. Lucy, thank you.
Thank you for this report. Like I said, I did think it was quite broad and lacked a lot of detail. And there's no real clarity about the strategy, how the strategy is being developed and refreshed. As part of the integrated care system, there's supposed to be emphasis on neighbourhoods, places, and systems. It'd be good to hear what work you're doing on the consideration of neighbourhood population health and mental health, and working with networks of GPs and primary care, as this isn't obvious at all from this. How will the strategy deliver neighbourhood population health improvements to mental health when need is greatest and outcome can be most improved?
Thank you for those points, Lucy. Thank you.
Shall I start? Maybe Gareth wants to come in. So part of the deliberation is how we map the community mental health teams against primary care networks and groups of GPs and their practice staff. So that work is going on now. That also brings in the local third sector in those places. And I think, again, there's a whole range of responses, some very well developed, co-located, integrated neighbourhood teams, and other places where we're further behind. So that's part of what we want to bring back, hopefully with a map and some numbers to answer your point about more detail. Gareth, do you want to come in?
Yeah, I think it's fair to say that there is that variation at the moment, and I think through this piece of work we're trying to draw out where the best practice examples, so we can try and hold up to the whole system and try and get that learning across. I think if there's a sort of plea we could put out for help with some of this is that we've had some boroughs be very helpful come forward and help us with a lot of the data that we need to try and get some of this analysis right. So KCW, so Kensington, Chelsea, Westminster, Brent have all come forward with data. We haven't had as much come forward yet from the others, and so to make sure that we do look at all that variation and making sure we're drawing out principles that will fit across our ICS, it would be really helpful if we could have a bit of a support in making sure we get every all the information forward we need.
And obviously, the request for that data has already been gone out to those individual boroughs that have not responded thus far.
Yes.
Okay.
Yeah.
Thank you. Indeed.
Thank you. And when do you sort of expect there to be more detail that might be able to come to?
So as Katie said, early next month we should have this together with the analysis of need and demand.
And then just separately, I didn't necessarily directly talk about this, but we recently, I know Westminster did as well, visited the MCAP at St Charles. And I was just wondering what sort of vision is for that continuing, because one of the members who worked there said that at the moment you're seeing it as maybe a year-long service, but that one thing I want to speak out in terms of communication is I think it's a great service, but if it's sort of got this temporary aspect to it, and I think the community should know about MCAS and it should be being spoken about more, but is there really going to be investment into the MCAS if it's a service that might only be there for a year? And are you planning to roll out more MCAS across?
So good questions. We do like the MCAS. It's been very successful. We set up originally as a temporary winter measure. We've definitely seen that less people translate for implementation care from there, and that the feedback and the service users are going through it saying it's really positive. There are many moving parts in the puzzle at the moment, and we'll be coming on to talk about consultations and the future of other parts of the system at the moment. And we have to sort of take these decisions in the round around where is all the funding available for. There's lots of things we want to have in there. MCAS is one of the things we want to have going forward.
Yeah.
So, but we have to make this decision about funding forward.
With the sort of recent news in terms of the Met Police in London and call out and having
completely agree.
Having sort of one place where people can know about the MCAS and be going to it. I think it's really important.
Particularly the communication is key to all of
and
this.
The communication of it knowing where people can go.
Jargon-free communication, understandable communication. Sorry, was that your hand going up? Or was it
going up per se, but I feel we will come back to this in the next item because it's quite central to the proposals for key mental health services and Kensington, Chelsea and Westminster.
Thank you for that, Caroline.
So 2 points. There now are alternatives to accident emergency in all of the boroughs, often run in collaboration with sector organisations like Mind. I don't think we've got enough communication with people who use it, feedback that they're very positive and welcome and well used. I think the more we can do that, the better. Only 50% of advanced calls come through to us to ask where one of those alternatives actually is. If we could increase the number of people, either through the Metropolitan Police or others, ringing in advance, they could be directed to the right place. So maybe with this meeting, we can circulate the details of those for your.
Yeah, it needs to be a big
campaign
around.
Yeah,
and money going into how people can understand where they should be going out. Because
And as I said, which is jargon free, which is understandable, particularly with all our emerging new communities.
Yes.
Thank you.
And just in terms of the MCAS, we're looking at the success of the existing one with a view to perhaps having one in the west of northwest London. So the other boroughs that don't currently have one at the moment.
Thank you. Did you want to?
Well, just to pick up, I think the communication has been a recurring thing for a while now. We've been sort of take that on board that we really need to get something out that is what is the local offering in each neighbourhood and community, and accept the challenge that we've tried but we haven't got there yet, and we need to do more. Just noting Rory on the screen as well, a real concerted effort of what the offering and who needs to know, targeted communication to community groups around.
And I think this morning is no exception. We were all together at and I think the thing coming out of the meeting was communication. So good. Thank you very much for those points, Lucy. Grateful to you. I'm going to come to Nick now, please.
Thanks. So in Eden, we're doing an in-depth review into children's absence. Get some recommendations. Through our investigations, obviously we found a very certain situation where the amount of need has grown significantly since COVID. And obviously the potential sort of follow through into adult and public service issues from that if they're not dealt, issues aren't dealt with appropriately and quickly. We've spoken to a few people in the ITS about some of the work that's being done in this area, such as the Pride mapping, which seems to be really, really good. But what I wanted to do is there any way you can basically run these two reviews in conjunction? Because I think one of the things we've looked at is the splitting between the two is not as helpful as if you look at them together, because there is a pathway all the way through. So, or at the very least, phase 2, where you look at children's mental health services, isn't relevant in phase 1 finishing, because from reading this paper, it looks like phase 1 is at the beginning stage, which is very good. But I feel like these things need to be together, to create the best whole system.
And also there's a bit in between. There's also a transitional period between one group to the other group.
Yeah. And actually, Katie might want to comment that the reason some colleagues aren't in the room is we're having a whole session on children and young people this morning at the Mental Health Forward. So I think those points are well made. It'd be great to pick up what you've been doing in Hillingdon. And Katie, what's the timescale for coming to the children and young people part?
So it will kind of run in parallel. So we'll add our focus of children and young people in October. That ties in with our refresh of our transformation plan for that group across North West London, and also brings in the work that ICHP are doing on Mission 3, so bringing in the innovation piece as well. But yes, really noted, and we have begun our work, so really happy to link in with what's going on locally as well.
Very good. I mean, our report essentially we finished in November. So
Okay.
I'm happy to share it.
Right.
Obviously, very happy to talk about it beforehand. It's 5 years. Oh, that's good. Okay, I just wanted to make sure that it wasn't like we do one and we'll do the other.
Yeah. So just and you're right. The number one issue in terms of increased referrals, I think it's 42% increase over the last 3 years in the children referrals as well as the
Thank you for that. Grateful. So I now make progress with Chetna, please.
Go to my first question is in regards to the planned engagement in North West London boroughs. Is this being planned alongside public health and engagement teams within individual companies?
Yes, so Rory can comment on that, but we work with the public health teams, the communications and engagement lead, and the local borough teams. So this is just a selection of what's actually happening, but I don't know if Rory wants to come in on that.
Thank you.
Yeah, That's right, Carolyn. We have a working group drawn from the comms teams of local authorities and the provider trusts and ourselves at the ICB. So it is all planned jointly across that group.
Thank you for that. Chetna?
Could we get any further details on that in the, when it's ready at the appropriate time, please? Yeah, thank you.
Perhaps a small paper might be helpful, but if that can be circulated for more information, please. Thank you. So Angela, please.
Thank you, Chair. There's a recognition in the report that the priorities for adult mental health services are currently not being met. And there are gaps in the offer. I see that you've got a plan to identify those gaps in October 23, but have you any idea what they are?
Katie, do you want to pick that up from the sessions we've done with service users and others?
Yeah, sure. So some of that has been coming through in our engagement at the moment. So various issues around accessing services, and then also support when they are able to access, but in terms of lengthy waiting times, the need to offer services in non-traditional environments, and then also looking at where there is experiencing isolation and loneliness, and which leads to exacerbation in mental health concerns. So they've come up with some of the gaps. Also, workforce comes through as a huge theme in the work that we've done, gathering views from the working group and through the engagement sessions as well.
Thank you. Anybody who wanted to supplement that?
I just think it's an important. Katie mentioned that ICHP Mission 3, so that's integrate Imperial College Healthcare Partnerships, in terms of children and young people mental health conditions, really growing our understanding of root causal factors to inform the solutions that we put into place, because a lot of the issues that we have are, as Katie says, around access to services, people's awareness of those services, the outcomes and evidence that those services are having the impact that we need, versus where is the evidence base for the underlying root cause of demand and the things that we need to do, intervening earlier and prevention. So I just wanted to flag the importance of that work into this strategy.
Thank you very much. Detna?
Can I just come into what you just mentioned? In terms of prevention, are we doing enough to look at things before they get really medium to long term? Are we going to different areas such as schools, with these kind of accessing parents, so that prevention rather than when it gets really bad, it probably costs more at that stage. So I'm very keen on the earlier phases and reaching out into schools as well, education sectors, and informing head teachers, school leaders, that sort of level, I feel is key.
Thank you, Carolyn.
I was just going to say there's quite a lot of work going on in schools in a variety of ways, including mental health teams in most of the schools in North West London. Our ambition is to have it in 100% of schools. We're just doing a stock take on what that means. So how regular is the input? Do we work with parents? Do we work with the staff? Do we work with pupils, etc.? So we could bring that back as well. But you're right, early intervention through schools is certainly one way to go.
Thank you. And Natalia, please.
Thank you very much. You mentioned that you're supposed to do the engagement with the voluntary sector, as mine has mentioned. So do we know at this stage what position is there in terms of mines at local level? Is it consistent across all partners? Is there also infrastructure for mines to provide the service at local level?
So we've probably got more infrastructure with mines than with most other sector organisations. There's also some supported housing and some crisis housing, some step-down houses with voluntary sector. It does depend on the borough and the patch a bit. So hence my point about trying to three the alternatives to other third sector organisations in other parts of North West London.
Thank you for that, Caroline. Gareth, please.
It's just worth mentioning that under the community mental health framework, which we were asked to roll out to the NHS long-term plan, specific funding has to go into each borough into those voluntary sector partnerships with the NHS. That's certainly a growing part of the landscape over the last 2 years.
So there will be open funding as well for this.
There is funding.
Yes, even not anything critical in terms of the work that we do.
Yeah, yeah. And we have, again, on this map, we could try and pinpoint that by borough, because it's different depending on the local third sector organisation, but we can put those contacts and some indicative amounts on there as well. We've certainly got that.
So just by way of reassurance and reassuring this committee, so I hear what you're saying, Caroline, that your trust obviously in your geography are doing some good work, but here right across Northwest London, I would be really keen to understand and be reassured. We would want to be reassured that there is a degree of uniformity, and with this new strategy, there is going to be greater degree of uniformity, and whether you're in Church End in Brent, or whether you're in Hayes in Hillingdon, or parts of Kensington or other parts, people are going to have, our residents are going to have, if not identical, similar experiences and similar outcomes.
So I think the idea of this work is to look at the best practice, and that came up in your previous discussion, and to try and spread it across Northwest London. So we know where there is better investment in third sector. We know where the beds are managed and people stay a shorter time because there's more follow-up housing. And it's really about sharing all that best practice. And a lot of it is just historical. That's how it's developed over the last X years. So shining a light on that and doing something about it is definitely one of our ambitions.
Great, thank you very much.
I think it's very important to highlight that the integrated care board's operating model, by defining standardised models and good practice, that the increased money, so there's been going about 7% a year increase, I think 30 million additional investment in mental health, that money then, as we're putting into these models, will ensure a redistribution to need and a redistribution to level the outcomes and the funding across the 8 boroughs. It's a difficult journey to analyse £5 billion worth of spend linked to outcomes and need, and the need to do that together in partnership. But that's the model that, if we get the strategy right, define the care models in mental health, that redistribution of funding will happen out of that model. And that's why it's so important to get that needs assessment.
Thank you. Lucy, please.
I was just wanted to ask you about the engagement and your strategy around breaking the taboo of mental health and what work you're doing there. Because I'm sure lots of it will be involving big communities, but also is there anything, you say you're going to have mental health teams ideally within your schools. But is there any kind of conversation around the curriculum and sort of seeing a future where young people grow up where they see their general health as important as their mental health? Because I think if it's transitioned in that, and I know that's how a lot of us think to work more in this area, but not all people do. And I think if people grew up being spoken to in a different way about mental health, but we wouldn't see half of the issues we do now, and a lot of the stigma that particularly middle-aged men see would probably change if they were spoken to at a younger age.
Thank you. Caroline?
So I agree with you. Part of the engagement is looking specifically at faith communities and communities that we haven't always outreach to or reached for whatever reason, and also men you highlighted as well. So we're talking about how we access those groups to best effect, whether it's face-to-face or virtual, etc., etc.
So we've heard about faith communities, faith groups, so faith leaders, but also we've got to be mindful that not everybody has a faith, and particularly with various emerging communities, people be mindful that although we are doing some excellent work with the faith leaders, we are not forgetting the emerging communities per se.
Yeah. Okay, well, if you like. Quite a lot of these, what we have to do is all breaking down the stigma, is working through sort of trusted intermediaries to reach sort of different communities. In many communities that will be sort of the faith leadership, but it's not by any means the only sort of means an average, so for housing associations, etc. So there's quite a wide range of different things. And one of the things we're really trying to do is to use the better data we have to be able to understand more precisely who have we got reached by. And then we can get into the which supermarket do they go to, which library, which age group, and so on, to enable us to target far better.
Thank you. Troy, did you want to add anything further to what we've just heard from Toby? Your microphone can't hear you. That's good. No, I think we've lost you. Okay, let me take the next question. If we can bring you back in, then we'll try. I think the tech perhaps is reaching us this morning. Let me bring Ben in. Ben?
Yeah. So not so much a question, but more a suggestion for a recommendation. Caroline, I think you referenced that there was engagement going on with the directors of adult social care. It'd be really interesting to hear more about that. And I'm just going to recommend that we receive a specific report from the lead DAT in Westminster so that we can understand that.
That would be great.
Yes.
Yeah. Thank you very much. Rory, I don't know whether the tech has been resolved. No, sorry, we can't hear you. I don't know whether you can hear us, but we certainly can't hear you. Okay, fine. Thank you very much. Any final, final question from Chetna then, please.
Just wanted to ask, are there any early indications of how issues are stemming from wider determinants of mental health areas of housing, cost of living, mental health for specifically men, certain stages of life, or women, stages of life, thinking about more holistic care, not everybody wants, the straight medical care, the doctor's capabilities, more holistic approaches at the earlier stages again.
So I think people are very much talking about the first two things you mentioned, cost of living and housing. I would say are up there, and 75% of the conversation. Also, a request for more holistic support, as you rightly said, not just medication, but more access to talking therapies, more direct referral, and more peer support. So those would be the top five.
And Gareth, I see you've been nodding your head, and I think you particularly have been. I think leading some good work around open dialogue. So maybe you just might want to just say a very, very quick word.
So it's absolutely clear that we need to do more on the social determinants work. It's absolutely, and that intersectionality that you were bringing up there about the deprivation and indices and the ethnicity indices and the mental health problems all intersect in the same spaces. When we're doing that analysis on a borough level and then down to ward level, we can start to see those we can see where we're going to be able to start targeting the approaches. And the chair is kindly supportive about open dialogue. There are new models of care that we can start looking at, and we are building a pilot in the demonstrator model that's happening in South Westminster at the moment around looking at an approach that is far more open to looking at people needing the regular care, and therefore being far more culturally open, far more led by them, and then be able to say what's important for them, and then adapting the approach each time to sort of care that can start.
Thank you. Thank you very much for that. So before I bring this paper to close, any recommendations? I know Ben has already alluded to one of those recommendations. Are there any, Nick?
Yeah, just basically get more information on the children and also aspect of that. So I'm really pleased to hear that good stuff is going on, but just important, that'd be very useful.
Thank you very much. Anything, Chetna, please?
Can we get more information about what I've just mentioned about the housing, cost of living, specific areas, and the way, the how, more on the hows, what's going to be available to them and how, and more even communication so people can open up an earlier stage before things get really bad. Like, can we do more work in the NHS on just having more open conversations where people feel they can come forward at an earlier stage rather than when things get too bad and it's kind of too late, that kind of work.
Thank you very much for that. Thank you to all the colleagues for your assistance on this paper. So I'm now going to make progress, and our final substantive paper this morning is Gordon Hospital, the consultation leading to Gordon Hospital the future of the proposal for the future of the hospital. And we have Toby in the room, and we have the colleagues at the paper. So I'm going to ask Toby to start, and then I will bring the other colleagues in. Toby, please.
Yes, so thank you, Chair. So I guess sort of a few things, but so I'll not try and rehearse everything which is in the paper. So the first is that while the paper is entitled sort of the future of the Gordon Hospital, actually what we're really talking about here is the future of acute mental health services for adult residents of sort of Westminster and sort of Kensington and Chelsea. Because at its heart, we have a decision on where to put our investment in mental health services. And if we put our investment into those acute mental health services into reopening the wards sort of in the Gordon, then it will have sort of knock-on effects for what we can fund sort of elsewhere, which might include the sort of mental health crisis assessment service. We were talking about some of the investment which has gone into supporting other sort of community services and voluntary services in sort of Westminster and sort of Kensington and Chelsea. So clearly the future of the Gordon Hospital is a central part of this consultation, but it's by no means the only part of sort of this consultation. We have been sort of progressing over the sort of months with a sort of series of workshops with all of our sort of stakeholders, including our sort of local authority colleagues, on the options to put forward in sort of in the consultation. There are sort of 4 at the moment which are under sort of active sort of consideration, and the final workshop on the options is scheduled for tomorrow. So that's a little bit of an accident. I'll be able to tell you exactly what's going into the consultation in 48 hours, but probably not quite at this moment. But the 4 options which have come through from the workshops are basically the a return to the sort of status quo ante, so what it was like in 2019, reopening the 3 wards in the Gordon, but the corollary of that is that a lot of the community services we put in place since 2019 would need to cease in order to be able to fund that. 2, basically continue with what we've got now, which is the acute inpatient beds are at St Charles. They're inpatient beds at the Gordon, but continue those sort of community services, and indeed the mental health crisis assessment service currently based at St Charles. Third option is remarkably similar to the second, but moves that mental health crisis assessment service from the Gordon from St Charles to the Gordon, to give us some sort of quasi sort of inpatient sort of facility in sort of Westminster. I say quasi because it's not sort of proper acute mental health, but the length of stays are much shorter, but that's there. And the sort of 4th option is whether we can do something smaller, so reopen 1 more sort of in the Gordon, and would say it's a sort of a bit of a halfway house. So 1 ward is obviously cheaper, so we don't have to cut down quite as many community services to afford it, but it's that. Those latter 2 options sort of came out very much from the workshops and sort of suggestions from sort of local authority colleagues, which is sort of why they are there for sort of active consideration. No matter what actually goes into the consultation as sort of formal options, we are committed to a full discussion of those sort of various options. So people responding to the consultation will be able to see the logic and the reasons for whichever sort of options we've sort of put forward, but equally the reasons for options which we've chosen not to put forward. So they'll be able to comment and tell us if they believe so, why they think we are wrong in what we have sort of put forward. So that's sort of basically sort of where we are. So let's say final workshop sort of tomorrow goes to our strategic sort of commissioning committee based off the workshop tomorrow, sort of towards sort of the end of the month. We've got in the paper a fair bit on the sort of proposal consultation sort of process. We'll have to sort of go into that in sort of some sort of quite sort of considerably sort of more detail. And then finally, we do have a little bit of sort of tidying up to do on the formal scrutiny arrangements for the sort of consultation sort of itself. Whereas what we put in the paper was, I think, the position at the time of writing of the paper, but it seems to have evolved since then, so a little bit as well, and I can come back to that.
Okay.
As well, if it comes up in the conflict.
Thank you. Did any of the other colleagues want to in? Okay, thank you very much. So let me bring Lucy first then. Lucy, thank you.
My first question to you is kind of like to confirm the report states that Kensal Town identified an area in RBKC of high deprivation. And and you'll be paying more attention to engaging with people in this area and other deprived areas. Kensal Town is not part of RBKC, and it's not on board in RBKC either. So just in terms of us reading this report, it was fairly concerning to read a location that's not remotely in our borough, and that too, as a community within RBKC, a private operation that you're engaging with. But just firstly, love some clarification on that. I'll go that, I'll go.
Thank you. To have that, it's little disappointing, isn't it, Toby? Not to understand or appreciate the geography or the population or the neighbourhoods.
Well, so we made an error in that, of apologies. Yeah, we've done quite considerable work on the so where the patients who have been going to the Northern have come from and where they are sort of going to and so. And that has highlighted a number of particular sort of communities where she did as well. Right. And we'll get we'll sort that.
Thank you.
What kind was it? Correct. And the report states that they will seek feedback from service users. However, there's no detail about how or challenges of engaging with vulnerable group patients or ex patients. I think it would just be the voice for patients on the substantial changes to these services needs to be at the heart of any of these changes, and it's fundamental to any reconfiguration of these services. And I just don't think either in this report or reports that come to us before at JOSC or in RBKC we've ever really truly heard what feedback from users of the board has been, or what users in terms of people who would have accessed the building that everyone else elsewhere. And I think it would be really, it may strengthen your case, but it would be really good for us to understand actually what that feedback has been, who you have engaged with, and more in terms of the challenges of reaching that group, because it just feels like there's a significant aspect of this that's been missing, and it's a very important group that you do. And it's also with, and we should be able to understand what those voices have said.
And just to understand what is coming to its benefits, obviously CNW has had a number of workshops led by, I think, CNWL or Forest CB. But it'd be good to understand what Lucy is saying, whether patients were part of those workshops, and it'd be good to understand what the feedback was like and what was the key things or emerging key things coming out of those conversations.
And as well as that, also families who were the support systems around those patients.
Absolutely,
yeah. Would affect everyone, but I think without a true depth of understanding of what those voices have said, I can't really have faith in understanding where these workshops
Thank you. So who's going to pick that up for me first?
Can you pick that up first, Gareth?
So they absolutely have been service users and carers of people who use the board facilities in the past. We've been part of every one of these workshops, and the same is consistently through, so they don't follow a thread of those who put it forward and that they help shape. They have there is a range of views from that group as well. There are some that are very clearly not aligned with our third options within that, but they have repeatedly stated that this process that they feel heard, and that they can see that the conversation has been talking and molded by the new options that emerged by hearing their voices within that. You also got something who align with the third options. So you've made sure that is, I think, part of that. And in terms of, as we head into the consultation itself, absolutely all demographic that we want to give having really strong communication with anyone who's previously used the board and services, and they will be very much talking about the consultation process versus the being consulted, and really encouraged to provide feedback on this.
And are we, as either our committees or jobs, are we allowed to see what the variety of feedback has been from service users? I know to what it is.
So yes, absolutely.
So I think that's something that really has been looking at.
So I think what would be, Lucy, would have been helpful, or what would be helpful, would be, like a table form, format, what, have been said by those individual service users, the families, the immediate families of the carers, to be able to make some sense, to provide this committee with some degree of holistic as to how this has been formulated. And I think also it'd be really good to understand. You said that those individuals have been engaged carers, and to have that continuity of that thread. They have been invited to the successive workshops. It'd be good to understand what the numbers of those individuals look like, to understand, how many people or how many individuals have been taking part. Lucy.
On top of that as well, I think, I don't know if I've asked this to you before, but how were those patients, users, and group of people who might be born, how were they approached within the competition? Were they selected to be the people who were? I'm not saying that it's a.
So I would say it's not a consultation. The pre-consultation, and I think it's a really important point to make that actually is that this is purely the pre-consultation work of developing our options as much as possible, because there will be a time now where we very much want to hear from as broad a range of people as possible. But in making sure that the information is provided in a way that's has been shaped by their voice, but that would very much be including them partnership and co-production throughout that development of this pre-consultation work.
And I think the point being made is leading up to this morning, just to understand, to have that reassurance about how all of this has been emerging in the previous period. So I think that is what the point that Lucy is making, the point that I've just made. Toby, please.
Just to give you 4 seconds. So the commentary and the output of all of those workshops are available to them online. So very easy to look at copies of all of those. They don't tend to pull out these specific comments from the individual service users as opposed to local authority partners and so on, but that's absolutely available. Alongside that, so we and CNWL have done some specific engagement events with all service users and carers. We've got all records of those and so on, so they're purely service users and carers without all of the other stakeholders, so we can actually give you these. We obviously have more slightly more historic, 2019 and so on, reports from service users on their experiences of using Gordon when the Gordon was open and accepting patients. So we can certainly share those. Some of them are quite complimentary. Some of them, I have to say, are actually quite harrowing in terms of how people describe their experience, but those are definitely available. And then the fourth bit, on the consultation, is where I would normally hand over to Rory to talk us through what we're going to do, but we can't hear him at the moment. So we should give you the fuller consultation plan on that. I can tell you that Rory has been working with the communications engagement officers in RBKC and Westminster City Council to ensure that we reach all of the people that we need to reach. But you're not going to take that period on an assurance from me. You want to see the paper.
Thank you. Thank you for that, Toby. Let us have another try and see if Rory is able to be heard. Rory, just say hello to see whether you're coming through. No.
I think what Rory might say is that we are investing more resources in the consultation phase in expert engagement support structure jointly, so that in building on what's already been said, we're making sure we've got people to coordinate that and reach out and hold the events during the consultation. Rory in partnership with all the various consultants.
He's saying yes. I can live with him, and he's saying yes, so that's good. Thank you very much for that. So next question, please. Angela.
Well, it follows on a bit from what Lucy was saying, but have you got historical evidence of the origin of people who used the Gordon? What percentage came from Tennessee?
They break it down by age, ward they come from, or to a super output area, so we can see where within KNC and where within Westminster ethnicity.
What the impact is on residents outside that area.
So within the Gordon Hospital itself, I think, I need to remember numbers, about 85% of attendees at the Gordon Hospital came from either Westminster or KNC. The bulk obviously coming from Westminster, because that's where it is. That's 60-25 and then sort of 15 from that sort of outside. We can see what the corresponding change in travel times for people who might now need to go to St Charles rather than Gordon would be. And we can break that down again by sort of ward or from a super output area into as to the additional travel time for indeed for their carers by it or bus, by public transport, by car, etc. and so on. We can also see that there's a quite considerable number of people who would have been managed in the acute inpatient setting who are now managing to manage in a community setting and who are hence having now to travel less. So we can give you the, this particular group is travelling a bit less, this particular group is travelling a bit more. You can see from that in particular, one of the areas we know we need to talk confident that some of our groups which have sort of higher sticker around that particularly sort of flat community, which there's a bit of a pocket around sort of Gordon, are particularly sort of disadvantaged by the additional sort of travel to St Charles, and they've been slightly less of a shift into community services than others. So, but that does allow us to be sort of really quite targeted in sort of what we need to consult on and who we need to engage with, and to the point earlier around that, really targeted with our engagement or methodologies to ensure that we reach these people, and it allows us to be sort of quite specific about the sorts of things we need to talk from the management.
Thank you for that. Grateful to you. Natalia, please.
Thank you, Chair. I just have a question. But why the trust limiting the scope of the consultation? And that's looking at Chelsea, Westminster, what's happening to the voices of the residents from Fulham, and I'm sure other residents from North West London.
So for this particular one, if you look at the resident, the attendees or the users of mental health services in Kensington, Chelsea and sort of Westminster, particularly the inpatient attendees at Gordon or St Charles, so 85-90% of them are residents of KNC and Westminster. And the next largest group are sort of residents from Brent, because St Charles isn't that far away from Brent, put them up the top, and that accounts for all the rest of them. And because services for mental health services for residents of health that we Fulham are provided by the Neighbouring Trust, the West London Trust, there's really very little flow across the border.
I'm just concerned that key voices won't be incorporated as part of the consultation, and it's not really in the spirit of integrated care, partnership, collaboration.
So we are in different different times now, aren't we, with the ICS, ICB, and I think the point that Natalia is making is the is that collaboration, and I think we don't have the data in front of us, but it'd be good to understand how many people are using the services from Hamilton and Fulham to be able to ensure that those service users or those families or those potential families views are going to become taken out. And that is the point that Natalia is trying to make. Gareth, you wanted to come in?
Well, just on that last point, I know that it's almost none from Hamilton in these hospitals, that the only time, very, very rare occasion it would happen is usually when we've got sort of cyclical arrangement with the other organisations, potentially staff members who are also patients. So it's almost never that would happen within this group. And the other thing, say, it was just responding on that previous point as well, that just we've got that analysis for Gordon and how it's being used for this residents. We have the same analysis for St Charles as well. So we'd be able to compare across the two. So we'll be able to. That is all part of what we've been developing in the pre-consultation work.
Thank you for that. That's really helpful. Did you want to talk? Okay. Are there any other questions, guys? Okay, I just wanted to understand a little bit about going forward now, please. So going forward, obviously, there is much on the website about what the process is going to look like around consultation. And again, I just want to understand it being, largely there, people who are, familiar with accessing information from the website would be, happy to do so. But what about, those who are not savvy, those who will not be familiar with where the information is on the website, what provisions are being made to make sure that there is in fact accessibility around this and there is information around this, so that every voice who wants to be heard is going to be able to be heard.
The answer to that is quite extensive provision, but Rory is our guru on this, but we can't quite hear from him, so I'm going to try and say it, and hopefully Rory will nod at the appropriate moments and shake his head if I'm going to wildly off-piste. So based off the sort of quite detailed analysis we have on sort of where patients who used to attend the ward would come from, and indeed what the current sort of plays are, we have been able to sort of break that down into particular sort of wards and so on, which are sort of quite sort of prevalence of usage. We've managed to mislabel which borough they're actually in. Apologies again. So we can see that. We can break it down by sort of the ethnicity, by the sort of the age and so on. And what we've done is to sort of build on all of the to the work which Rory has been doing in our sort of broad sort of involvement strategy to sort of identify the or the groups or the intermediaries and so on, which enable us to access sort of those particular sort of communities. So we have quite an extensive sort of schedule of these are the particular groups we need to sort of reach. These are the ways in which we have reached them before. And this is therefore who we need to speak to in order to access them. And these are the sorts of sort of messages or sort of ways of reaching them which seem to be effective. So there is a
targeted or there is a planned program to do
outreach program which is quite
all this outreach work,
which is quite granular in identifying the groups, the types of messages which sort of resonate with those groups, and the methods of outreach which sort of work for those groups. So for some groups, sticking stuff on a website and sort of is that sort of absolutely brilliant. They're not. That's what other groups don't never read anything. So you therefore need to be going to the library, which one where they're going to, or the local supermarket and so on. So it's quite sort of granularly broken down into how we do that. I will then add that we then sort of test that or work with or local authorities or comms colleagues, because you, as we said, know your populations better than we do. So we think we've got a reasonably good handle on it, but we're not going to sort of turn down a sort of proper expertise where it's available to us, sort of test and sort of find that.
Okay, thank you very much. Angela, and then let's see what I don't know whether that was hand going up or you. Okay, thank you. Angela, please.
Right, I have a question here. Have they taken into account the Mayor of London's 36 tests to any reduction plans for healthcare service reductions?
So we have done some preliminary work on Mayor of London 6 tests. The Mayor wrote to us last week, maybe the week before, I don't forget exactly when, confirming that he is going to be applying the 6 tests to this sort of particular sort of proposal. As is the sort of standard sort of methodology for when the Mayor does that, the first 4 tests he will run in conjunction with the first part of the consultation, and the second 2 tests, which are more around the efficacy of the engagement, he will then sort of run after the consultation, because this could affect testing how effective the consultation has been on reaching the relevant groups. So yeah, we're doing the work on it. I expect we will have lots of scrutiny and working through with the Mayor and his team on the sort of particular points to come.
Thank you.
Thank you. Yes.
Point in addition to that, we've got an NHS England process and key lines of inquiry around this whole process as a very important public consultation. So we have both the NHS England tests, your scrutiny here, and the Mayor's 6 tests, which will be forms the basis of our pre-consultation business case, which has been through ultimately for a decision-making business case post.
I think Dr. Trump copy is going to be making his things, so we have through me we have a resident sitting in the public gallery, and I'm going to do my very best to paraphrase one or two points that our friend in the public gallery wishes to seek some clarity. And this is around the funding and resource issue, particularly to do with St. Charles's offer. So just want to understand, so there is going to be a lot of information available, but that information includes about the funding and the resources that are going to be available, and the fact that the community focused work that is going to be happening, if the options that you were either outlining earlier is factored into all of this as well, or would the public need to seek more clarity, or is it out there already for people to digest?
I've got things out there already. So there's certainly quite a bit of it in the workshop and sort of reports I was referring to, which are sort of online.
Yeah.
Quite how immediately digestible they are, people who weren't in the workshop, I would need to go and check. But it will be clear. And
so I think it'd be really helpful about the funding and financing if there is jargon-free, digestible, to be able, for the residents, local populations to understand that about the funding issues, the result issue, and how the new model of care is going to be providing outcomes, better outcomes, different outcomes.
That's absolutely a core part of all of the pre-consultation work we've been developing now. So the descriptions of where the public is, where it's gone. I think the key headlines from this are we're spending more on this healthcare system for its mental health than we were back in 2019. It's gone up during this.
So I think that is what you heard in healing, when you were healing. I think that is what you very clear mode was saying. But I think since we're looking at this consultation going out very soon, I think for people to be able to understand what's it's all about, and if they have missing pieces of jigsaw, then they won't be able to give you the complete voice, and there'll be some gray area. And I think it'd be really good to be transparent and be helpful, so that residents can make an informed voice to you guys. Yes,
I'll make an important point, Chris. This is about how we are investing extra investment in mental health services year on year, increased investment overall to make the best care models for our residents and populations. It's not about saving money.
Okay. Sorry, the other points that the colleague has raised, I'm not going to raise those at this stage because it's about consultation rather than anything else. But thank you for that. Are there any other points that we want to raise about going forward with consultation? And I guess the key point to ask would be, we had the Ealing mental health beds, Caroline, which obviously you're familiar with. And I wonder whether there has been any learning from that scenario to make sure that, this time round, there is that positivity as far as the ability to make those connections.
I think there's a few things. One, the points that Toby and others have brought out on the pre-consultation, making sure that everyone's engaged at a very early stage and in designing the options for going forward. And then,
which I think we have touched on already.
And then I think the points that have come up about making that information clear, including finances, so that local people can understand where the money's gone and what the options are going forward.
Thank you.
So just bringing a point from Rory, I've had in, thank you, Rory, to ask that if there are, in terms of, we've talked about our engagement and with community groups, if there are particular suggestions from the particular areas we're missing, or areas you'd like us to particularly focus on that are not coming through,
and I think
just let us know and we'll make sure that's built in.
And I think that was the case with Caroline, your work as well. So thank you very much for that opportunity. Grateful to you. Lucy, I think you were raising your hand.
Yeah, I was just saying in terms of I think you also meaning committee was in regards to both Westminster and RBKC had conversations saying that we do think there is an argument for a more focused and concentrated community that's for the boroughs that are most effective. But obviously, we also appreciate that this is the jobs and want to hear what everyone feels about it. That if there's a majority view that it should be agreed to a committee, then it should be. But it's just more about getting the best results for our residents. And as we hear, 85 to 90% of people that are users of the Gordons are Westminster and RBKC. It's not about shutting everyone else out. It's about how we can do it for everyone's best possible use of time and how it can be most effective to us. So, I mean, I'd be very much welcome everyone's views, and it should be a just decision. But that was our general thought processes, that we did think that, but we would welcome hearing from you.
Angela, please.
Well, can I say, I agree with Lucy. I mean, the idea of something more focused thought might possibly be more helpful, but I think it's also important that others don't feel excluded. I think it's useful to get a feel.
So I think it is absolutely open to the individual boroughs to look at this from their borough perspective. Absolutely, and that's like in the statute. So there is absolutely the opportunity to do that. As far as the JOSC itself is concerned, happy for any other views. As far as this coming back to JOSC is concerned, so our next meeting would be in December, and that is when perhaps if provide this committee with the opportunity to review how well the consultation has gone. Yes, Toby.
Sorry, Chair, to interject. I think we need to be clear on sort of the legal point here, which is that in response to a consultation, then there is a legal duty on the affected local authorities, and we can debate what we mean by affected here, which is, I think, the question to Councillor Knight is bringing up. But there is a sort of legal duty on the affected local authorities to form a single JOSC, and it is that single JOSC which then provides the formal feedback to the consultation, and in particular can tell information from us, and if necessary decide to refer on to Secretary of State. So one of my learnings from the Hope and Horizon work would be the need for sort of absolute clarity on what that formal JOSC is. So whether it's the 8 together, that's fine, or whether it's KMC and Westminster and a small bit, that's also fine. But it really has to be sort of one of those sort of two things. And I don't think we can have a sort of an ambiguity that sort of the whole JOSC we consider it and the individual OSCs can consider it, because the law is quite clear that the responsibility for formal response must sit with one scrutiny committee.
Okay, any views, colleagues? Nick, please.
So legally, in my opinion, this doesn't affect us directly. So I'm happy to sit it out, but ultimately want to support Lucy and Angie in their perspective. So whether you guys need to spec something, go along with, but personally, if you see myself reasonable, it's something we need to.
Yeah, I think from our side, we want what the majority of the jobs wants, but that's our viewpoint. It's in order to do that by our residents and have the most accessible feedback.
Thank you.
Thank you. But we want to.
Marina, please.
There's one thing that your health plan will be interviewing.
We can know that was said a few moments ago.
Which I think we would do. You meeting in within committees.
Yeah.
Yeah, I think if it's a view that all the jobs want to look at it, then that's what we would go with. But obviously that needs to be a majority decision.
Thank you. No, Jetna, please.
I feel from representing Harrow, because it's very difficult to contribute because we don't have any data on how it's having any impact on us. So I find it, I'm happy to support, but if you decided to create something that was necessary, I'm happy with that.
Okay. Any other view? Yes, Ben.
The impact because I've already seen the data in terms of people from Ealing is minimal. So we would wish to be involved in that conversation. Therefore, I would probably support the formation of a smaller community outside of jobs.
Okay. Natalia.
I would value the opportunity, not for the whole ongoing process, but at least to have some opportunity to input and to give feedback from a higher perspective. And the residents, I think, we have responsibility with our patients and residents as well. And as I said before, in the spirit of collaboration and there's no changes in things coming back going forward. I think it's important to be able to have at least one opportunity to honor this.
I think that would be possible. Thank you. So I think Rob wanted to come in.
So there's also something about learning the context of the overall strategy that we're operating to across North West London, and sort of the different components of this, because it's immensely useful to have all 8 local authorities contributing, even sometimes when there is not direct impact in things, and keeping us all on the same page in what we're collectively trying to achieve across North West London for our residents. Notwithstanding that, if there are legal dynamics and different approaches once to be taken locally within that, create a process that what needs to be done. But I think it would be a shame in any of our processes to not recognise that there'll be JOSC across the 8, given there is going to be a differential need locally, but the need for getting best practice service models and strategies and principles agreed that operates within, and then take however that is impacting locally through appropriate processes that you are describing.
Okay. Wasn't looking to spend a lot of time on the admin and the process, but since this has been raised, how do you guys then want to then take this forward? So obviously there is the ability for us to have this paper back in December as a JOSC to have the updated paper following the consultation, or not to have it at all. And for Kensington and Chelsea and for Westminster, the individual boroughs to look at it in their own geographies, and any other boroughs that may want to look at it, there will be obviously the opportunity for those boroughs to bring this paper to their respective scrutinies additionally, which is obviously also possible. So I think those are the 2 options. It's not something that I wanted to debate in this public setting, but since it has been raised, I think we need to have a resolution. So how do you guys want to take this forward? Yes, Nick.
I mean, who here amongst us as committee members wants to be directly involved? Because my personal feeling is I don't need any more updates unless Lucy, Angela, or whoever else is interested, or even Rob come back and say, actually, it's a bigger Southern issue. At the moment, I'm quite happy stepping back completely, and that's the bigger London issue. So thank you much.
Okay.
Is it possible to have a 2-step approach where the ones who'd like to be involved have a separate something, and then a brief update in at the next junction, as Natalia would like? Is that a possibility?
So those are possibilities. So we can have an update paper. Again, we're spending rather too much time on this. We can have this paper back, update paper in December, if that is what the committee wants to do. Or if the committee is minded not to look at this back, to have this back at December, then that is the committee's decision. Yes, Nick.
My suggestion is we don't have it back unless you, as chair, decide in consultation with others who are directly affected that it's more than North West agenda. So I think we shouldn't stipulate it. Obviously, I know you're going to maintain the interest. I'm sure you are.
Okay.
I say that it's inside the North West agenda is there, and the option for having it back.
Okay.
That's my view.
Okay. Okay. Fine. So in that case, I will discuss with Natalia and Rob and then we will decide whether this needs to come back in December. If it doesn't come back in December, then so be it. And of course, it is open for Kensington and Chelsea and Westminster to decide how you guys would want to do it, because obviously that is the option available to you both. Sorry
for sort of raising it, I just think it was better and
No.
understand what our viewpoint is and
Absolutely.
what you.
Absolutely. And I think we shouldn't spend any more time on this. I think we've spent enough time as it is. So thank you very much. But is there any final recommendation around this pre-consultation or going forward with the consultation is concerned? Okay, fine. If not, then there are two other papers that we need to note, which is the recommendation tracker. Are we happy to note that as tabled?
Yeah.
Thank you. And then we have the work program also at the back of the papers, and I suggest we note it. The only thing that we need to do is I will work offline to decide whether we want to bring this paper back in December or otherwise. Ben, please.
Yeah, so a couple of things. I understand there's ongoing discussions within the ICS about the scope of its review of the Better Care Fund. I do think that that's expected to be forthcoming over the next couple of months. I'd like to suggest that Joss have some oversight of that in terms of the scope of the review. And then I understand there's also a national programme for ICS to reduce overheads and central costs, and that we're looking for our ICS to reduce costs by about 30%. There is likely to be a significant impact on local NHS commissioning and also leadership. So I suggest that we look at that as a committee as well.
Thank you very much for those incredibly helpful suggestions. I will work with the NHS colleagues to see when it is appropriate and suitable in terms of the timelines to bring those forward. Thank you very much for that suggestion. Emily, I'm not aware of any other business. Thank you very much. So until we meet next time, thank you very much. And I'm sorry for the brief hiccups that we had at the start with the technology, and I think there are one or two hiccups during. So my apologies for that. Have a good afternoon, whatever you guys are doing. Until next time, thank you very much indeed. And finally, well, very final point.